All right, good evening, colleagues. Welcome to our webinar today. Yeah, we're pleased to be presenting this webinar series. And once again, we're presenting the standard operating procedures for the Ministry of Health and Medical Services, particularly for this COVID-19 outbreak. And I'm Dr. Alipati with Clinical Governance. The aim of these webinars is to try and make sure that our standard operating procedures filter all the way down so that people understand what the principles of the SOPs are and adhere to it. So today we have a very interesting presentation on the rapid diagnostic tests for COVID-19. Obviously, this is something that's definitely going to be come to the fore more and more as we move into mitigation across the Viti level. We have Dr. Alisha Sahukan, who will be presenting on the RDT for today's webinar. Okay. So for housekeeping again, colleagues would humbly request that you please ensure that your mic is muted when you come in, so that our presenter doesn't have any issues with the presentation and everyone can hear. And somebody's mic is on. Let me just mute everyone again. Okay, so please be mindful that sometimes the mics can come on automatically. Kerker, if you can just ensure that it's off. If you have any questions that may come up during the presentation, please place them into the chat box and we will address them at the end. Otherwise, we will give you time to ask a question to the presenter, Dr. Alisha, at the end. Thank you. I think that's it for housekeeping, and we will hand over to Dr. Alisha Pinaka.
Thank you, Dr. Alipati. I'm just trying to pull up my presentation. Thank you. I just want to check that I have the Fiji CDC team online. Shalini, are you there?
Yes, we are.
Okay.
And
yeah.
Good evening to all.
Thank you.
Wait.
Okay. So what we thought we would do is, first of all, thank you very much for this opportunity to present on RDTs. I know that there's been a lot of interest on this new testing technology that we've launched, first from the Ministry of Health, and I know there's a lot of private providers who are also interested in it. We're going to start off, there'll be two parts to this presentation. The first part, the Fiji CDC team will demonstrate, do a demonstration of how to use an RDT kit. And this is based on the kits that the Ministry of Health is using. And once they're done, then we'll switch over back to me and I will present on RDTs in general and the ministry's stance and protocols on using RDTs. So I'll hand over to Shalini Singh, who is one of our lab scientists at the Ministry of Health and Medical Services, Fiji Center for Disease Control. And I'm not sure if Talitha is there as well, our lab manager. No. But anyway, I'll hand over to Shalini. Thank you.
Thank you, and good evening to you all. We'll share the screen with our PowerPoint presentation. I'm here on behalf of our laboratory manager, Ms. Talitha Dambe, my wife, who's not able to make it today. So I have with me my colleague, Dhanvagyam Gounder, and we'll do a short presentation. Then we'll just, during this presentation, we'll just go over with the rapid tests, what it contains. And also we have a very short video in a very simplified way, just to show what the test is actually like and how you set up the test and interpretation of the test. We're just sharing the screen. Can everyone see the screen?
Yep, go ahead.
So there are two actually types of rapid tests currently in Fiji with Ministry of Health for the COVID-19 antigen testing. One is the standard Q COVID-19 antigen SD biosensor kit, and the other one is the 10 bio kit. So in terms of its principle, this test is a qualitative test for detection of specific antigens to SARS-CoV-2 present in the nasopharyngeal, in the nasopharynx. And this is a screening test. And one thing we have to be quite cautious is that this is strictly for medical professional use only, and it is not intended for the general public personal use. And the gold standard assay for COVID-19 is RT-PCR, like what we have here at Fiji CDC, and also gene expert testing, which is in other divisional and subdivisional labs. In terms of RT-PCR, we have specialized equipments that are used, and also staff has to be highly trained in this area. And with availability of this rapid point of care testing, it enables the healthcare professionals to actually quickly diagnose COVID cases, especially in terms of our situation where there is high community transmission going on. So basically the principle of this test is that it has two pre-coded lines, which is a control and test line. Some of the laboratory staff on this forum, or you may also be aware, like in terms of dengue rapid testing and lepto, or like pregnancy test kits, where you have this cassette sample is added onto the sample well, and then it migrates through into the membrane or filter paper that's there. So there is a control and test line, and when the samples are not added, the lines are not visible. After the samples are added, then the lines are visible, and mouse monoclonal anti-SARS-CoV antibody is coded on the test line, and mouse monoclonal anti-chicken IgY antibody is coded onto the control line. And during the test, the SARS-CoV-2 antigen in the sample interacts with the monoclonal antibodies, and then with the color particles, there is a antigen antibody color particle complex, and then it migrates into the membrane, and where the lines will be visible. We also have a control line, which my colleague Dhanvagyam will go through when she is talking about the interpretation of the tests. Some of the standard precautions that needs to be adhered to at all times is use of PPEs at all times during this testing. And one of the other important things is that please ensure that the test is conducted in pairs, like a buddy system, whereby one person is collecting the sample and the other one is performing the test, while the other person has taken the tube, and the gloves can be changed by the person who has collected the swabs, and then assist the person conducting the testing. But I suppose in drive-through situations like we've had here in Suva, there are several people that are there to help, which makes work really easy. And there has to be a designated area, clear designated area, where each of these things are being conducted. And within the designated area, you have to have your clean area and your dirty area. And in terms of some of the warnings, actually, the kit should not be reused, and the kit should not be used if the pouch is damaged or the seal is broken. Do not use the extraction buffer of one tube to another lot. So if you have one set of kit there with one lot number, and then you have a new one and you have some things finished in this, please do not mix the lot numbers. Do not smoke, eat, or drink while handling samples. Please take this as a really precaution that needs to be taken into account, that you are not to have your water bottles or any of your food materials where testing is to be conducted. Wear PPEs at all times when doing testing. Any spills should be thoroughly cleaned up with appropriate disinfectant, either 10% hypochlorite or 70% ethanol. Handle all samples as if they contain infectious material, and observe established precautions against microbiological hazards throughout testing procedures. Dispose of all samples and materials used to perform the test as biohazard waste. And the desiccant in the foil pouch is to absorb moisture and keep humidity from affecting the products. And there is a color change if there is a change in the humidity and so on. So Dhanvagyam will elaborate on that. And in terms of kit storage, the kit can be stored at between 2 to 30 degrees out of direct sunlight. Kit materials are stable until the expiration date printed on the outer box. Do not freeze the kit. And materials required but not provided in the kit is PPEs, your timer, which is very important, biohazard bags, your disinfectant, tissue paper, permanent markers to label your cassettes. You will be providing the cassettes with what we saw at the drive-through here in Suva is that they had pre-labeled the kits with the patient names and so. But when it came to the lab station where the testing was carried out, a lab identifier is also given. So there's 2 identifiers, a lab number plus the patient's name. So in terms of test procedure, Dhanvagyam will go through the test procedure. So, undo the screen. Hello, everyone. I'll just quickly show you the 2 kits that we have. This is the standard Q COVID-19 antigen test, and this is the PenBio COVID-19 antigen test. So I'll go through the kit contents with you. Firstly, for the PenBio, we have our nasopharyngeal swabs. We have extraction tubes with caps. We have a quick reference.
Sorry, guys, you just got muted over there. Can you unmute yourself, please?
Sorry. Okay, I'll just go over the kit contents again. We have nasopharyngeal swabs, the kit insert with a quick reference guide. We have buffer tubes with caps, the test device which comes in a foil pouch, and the buffer. So this is for PenBio. What happens is that get yourself an extraction tube and you add the test buffer to the mark. So that's around 10 drops till it comes to the mark. And we'll just put a cap on top of that. So after that, you'll be taking out your patient's sample.
using the nasopharyngeal swab that is provided in the kit. So let's say we have taken out the sample. So what we'll do, also ensure that you give an ID on this buffer sample tube as well, so that you don't mix it. So once the patient's swab has been taken, we'll insert inside the tube, rotate it 5 times, and then squeeze, and then break off the swab stick and put it in the rack. So what you do now is open up the test device. So what we have in the test device kit is a desiccant. So if it not valid, so this is the test device. As you can see, we have a C and a T mark here. This is your result window and a sample well. What we'll do is add 5 drops. As you can also see here, 5 drops are made here, so we'll be adding 5 drops. So what we'll do is open the bottom of the buffer tube and add 5 drops. And we'll set our timer to 15 minutes. And everything, we'll throw it in a biohazard bag. And quickly moving on to the standard Q test kit, which is being used by the dialysis centers. So this is also similar, but a bit different. So it also has a test device. It has extraction buffer tubes. It has caps that come separately. It has a kit insert, nasopharyngeal swabs. So in this kit, the buffers come in a tube, so you don't have to add anything. So let's say we're taking a patient swab. So once the patient swab is taken, we remove the foil cap from the extraction tube. And we'll squeeze and then mix 5 times. Once it's mixed, then we'll just squeeze and take out the swab and throw it in a biohazard bag. And we'll place a nozzle, which looks like this, on top. So we'll place this aside and open up the test kit, test device. So this is the test device. Always ensure to check the expiry date. This kit also comes with the cassette and the desiccant. As you can see, it says if it's yellow, then it's valid. If it's green, then it's invalid. So this one is yellow. So this is the test device. This is the window, the C mark and the T line. And well, for this kit, we add 3 instead of 5 as in the previous kit. So I'll add 3 drops and we'll wait for 15 minutes. And we'll throw all our oil waste in the yellow biohazard bin. For our pen biokit, you can see the C line is visible now, and the T line, there's no line in the T, so that means this is a negative test. So we move on to the interpretation. So interpretation of test, if it's a positive, you will see a line on the C or the control line and on the test line. So that means it's positive. Even if it's a faint line, you still take it as a positive. For negative, you'll only see a line across the C line, which I just showed you now. And if there is no C line, only the test line, that means the test is invalid and you have to repeat.
Dr. Lisha, do we have time to play with the video for one of the tests?
If it's okay with Dr. Alepati?
Yes, sure, go ahead.
Yeah, sure.
I hope you guys can see the video.
Yeah, we can see, don't hear anything yet.
Yeah,
Yes.
there's no volume in there. No.
So thanks, guys. But could you please share the link or web URL for that video? Just share it in the chat so that we can get people to view it again with sound. But thank you.
Sure. It's on YouTube. I'll send you the link shortly.
So that was all about the actual technique on how the test is to be conducted, but just would like to highlight a few things in terms of the timing. The test should not be read within 5 minutes of adding the buffer or 10 minutes, but at 15 minutes. If the test kit says 15 minutes, please put on the timer for 15 minutes. You'll have several patients coming in if you have a drive-through. So you may have to have several timers or people timing. So what we did was you could indicate the time you have added the buffer onto the cassette for each of the sample, and then you could note it on the request form. So whoever is reading it would know what time would the 15 minutes be, and then that cassette or test device needs to be read at that particular time. So please pay particular attention to how the test kit is to be handled, and also in terms of storage of where the test kit is stored at all times. And pay strict attention to PPEs, please. Thank you. So Dr. Alicia, would you discuss on the algorithm?
Yes, thank you very much, Shalini. I'm just going to take over. Let me just try and share my presentation. Dr. Alipati, can you see my screen?
Yep, nice and clear.
Okay. Thank you very much to the Fiji CDC team. Thank you, Shalini and Ronika, for that demonstration. So we just wanted to start and show you how to use the kits, what's involved, so that you can get familiar with the kits themselves. Now I'm going to take you into more discussion about laboratory diagnosis of acute COVID-19 infection and where the RDTs fit in. Firstly, on the global stage, and what are the WHO recommendations, and then what we are doing here in Fiji and what the Ministry of Health has published as our standard. So when you talk about laboratory diagnosis of COVID-19, we're specifically talking of diagnosis of acute infection. So the methods I'm talking about are to diagnose acute disease. So I've deliberately left out any reference to antibody testing, because we know that antibody testing is not recommended for the diagnosis of acute COVID-19. So first of all, the gold standard for diagnosis based on laboratory testing is molecular testing. So this was the first tests that were invented for COVID-19. Sorry, let me just start my video. These were the first tests that were put in place when the virus was first found at the beginning of the pandemic. And it's based on the detection of unique viral sequences by nucleic acid amplification tests. And so this includes the real-time reverse transcription polymerase chain reaction, or RT-PCR. And RT-PCR includes the open RT-PCR that is done up at Fiji CDC, but it also includes the gene experts machines that are very well known now in Fiji. It's just an open system, which is what is done at Fiji CDC, versus a closed system, which is the gene expert machine. So the advantage of the gene expert over our open PCR is that, of course, the turnaround time is quite fast. You can run, usually it's 4 samples in about an hour, whereas an open PCR takes about 6 hours. The disadvantage, of course, is that there's reduced throughput. So with the open PCR, you're able to run possibly 600 to 800 samples in that same time period. But of course, we have had really great success in using the gene expert machines because they can be deployed to much smaller labs. They don't need as much of a big setup like we have at Fiji CDC, which currently has 3 specific rooms that are reserved just for the open PCR. So when you're doing PCR, you're targeting the targets for the PCR specific genes that are specific to COVID-19, specific to the virus that causes COVID-19, which is SARS-CoV-2. And the ones that we use, we have in Fiji, the open RT-PCR detects the E gene and the RDRP gene. And then our gene expert is the E and the N genes. There's a bit quite interesting, the S gene, if some of you were reading when the Alpha variant came up in the UK, what was known then as the UK variant, you actually saw dropouts of this gene, which is the S gene. And that was how they first detected that they had a different variant in country. Next, of course, for the acute diagnosis of COVID-19 is a rapid diagnostic test. And that's why we're here today, to talk about RDTs, specifically antigen detecting RDTs. So antigen RDTs, as Shalini has described, directly detect SARS-CoV-2 antigens, which sit on the surface of the virus. And these are proteins, and most often the protein that's targeted is called nucleocapsid. And it's produced by the virus in respiratory secretions. So this is just some photos from the lab at Fiji CDC demonstrating the NAT testing, or RT-PCR, just to give you an idea of what the setup is like. So you have your biosafety cabinet and our team here doing extractions, manual extractions of the viral RNA. And then we got the 2 different systems here. One, of course, is the gene expert, which is the quite a rapid system that puts out results in about an hour. And these are 4 modules across the country in various labs. And then you have the PCR analyzers, which are used for the open PCR. Right, so back to antigen RDTs. So antigen RDTs are easy to use. You can see from the demonstration that Shalini did, they're quite simple to use compared to other laboratory tests, and they're either meant to be at or near point of care. So the turnaround time is usually about 30 minutes from when you collect the sample that you can give a result to the patient. However, the accuracy of the antigen RDTs depends on a number of factors, including the time from onset of infection, the concentration of virus in the specimen, and the quality and processing of the specimen collected from the person. And of course, the precise formulation of the reagents in the test kits. There are thousands of antigen RDT kits in circulation around the world, and none of them are of the same quality, which is why we do need to be very careful about what we do allow to be used in Fiji. Antigen RDT kits do require respiratory samples, and a lot of them require nasopharyngeal samples, but there are also options for other respiratory samples like nasal samples and saliva samples. In Fiji currently, we are just recommending nasopharyngeal samples and nasal samples in specific conditions. So in terms of accuracy, the WHO recommended performance criteria is more than equal to 80% sensitivity and more than or equal to 97% specificity compared to an approved NAT or PCR. So let's talk about what that means. So that is the recommended performance criteria. So test performance of these RDTs is determined by sensitivity and specificity. And if you remember what is sensitivity, so sensitivity is a percentage of cases that are positive by NAT reference standards that are detected also positive by the antigen RDT that's under evaluation. Specifically, what we don't want with sensitivity is a lower sensitivity where you get a high number of false negative results. So you're testing in a population, someone is symptomatic and they test negative on the RDT and it's a false negative. And the specificity, of course, is the percentage of cases negative by the NAT reference standard that are also negative by the antigen RDT that's under evaluation. So looking at the advantages and disadvantages of both the NAT testing or the PCR versus the RDTs. Of course, the NAT testing detects active COVID-19 infection. It's very highly sensitive and specific. Sensitivity is over 90%, specificity is over 95%. However, the disadvantages, as we all know, is the turnaround time, which can be hours or days after sample is collected. It's also labor intensive and it requires a lot of lab infrastructure and is more expensive. The rapid diagnostic antigen kits also detect active COVID-19 infection. They can be used at point of care outside laboratories. They're easy to perform, they're quick, and they're less expensive. However, their sensitivity and specificity is generally lower than NAT. And lower sensitivity means that negative predictive value is lower than the NAT, especially in settings with high prevalence. What this means is that if you're in a high prevalence area and you have someone who's symptomatic for COVID-19 and they test negative on RDT, you should be quite suspicious of that result, and that sample needs to be tested using a NAT, needs to be confirmed by NAT, because we know that the sensitivity is lower in high prevalence settings. And then when you have low prevalence settings, the positive predictive value is compromised as well. So that's why you may have an increased chance of getting false positives in low prevalence settings, which is why the use of the RDT is not recommended in low prevalence settings. Okay, so when we talk about the accuracy of the test and the test performance, we prefer not to rely on manufacturer supported studies. So the package insert that comes with the test, we don't rely on as much. We rather have independent studies or independent validation reports to determine the performance of an RDT. So this is a validation study that was done at a hospital in Geneva for both of the RDTs that are currently being used by the Ministry of Health and Medical Services. And both these RDTs, of course, are on the WHO's emergency use listing for antigen RDTs. So what this study found was that for the PanBio kit, which Ronica did show, the Abbott PanBio kit, the sensitivity and specificity, sensitivity was 85.48% and the specificity was 100%. So of course, very good specificity. So that means that in a high prevalence situation like what you have in Suva, if you get a positive result on this RDT, you will take that positive result as a positive. However, if you get someone who's symptomatic and they are negative for the RDT, it's still got quite a good sensitivity, but you would still want to confirm with the NAT because it's got a lower sensitivity than the NAT. So there's a chance of a higher risk of a false negative. And then looking at the other kit that is also on the WHO EUL and what we also use with the Ministry of Health, this is the SD standard Q antigen test. The sensitivity was 89% and the specificity was 99%. And then we've got another study. I just wanted to include this because this was published in the Lancet, and it was a real-time validation of the PanBio kit, also one of the kits that Ronica was showing. And it found that the specificity was very good. It was 100% in both the locations that the validation happened. So in Aruba and in the Netherlands. However, the test sensitivity was 72.6% in the Netherlands and 81% in Aruba. So a bit less than what was expected. So what they found was the probability of false negative results was associated with RT-PCR CT values. So what is called the RT-PCR cycle threshold, which can be correlated in some loosely to viral load. So if you get the higher the number, the higher the CT value, it's predicted that the viral load is actually quite low. So it's opposite, it's an inverse value. So what they found was that when they restricted, they tested these samples, these positive samples with RT-PCR, and then they tested them with the RDT. If they only included the RT-PCR positive samples that had a CT value of less than 32, then the sensitivity of the RDT went up to 95% and 98% respectively. What this tells you is that the RDTs are very good in detecting disease when someone is symptomatic and when their viral load is expected to be quite high. It may not be good at testing active infection very early in infection when the viral load may be lower, and very late in infection when the viral load may be dropping. So that's something very important to know, that the PCR will pick up quite low viral load, which is what we have seen in Fiji as well. You know, someone can recover from infection and 3 months down the line still test positive on PCR because it's still picking up that viral RNA or the dead virus. Okay, so for WHO recommends the use of antigen RDTs in specific settings. So they only recommend RDTs that match their performance criteria that has been mentioned, the sensitivity and the specificity, and in areas where NAT is unavailable or where the health system is overburdened, and where lab testing is also overburdened, where NAT turnaround times are more than 48 to 72 hours, which has happened in Fiji with the recent surge in cases. RDT should be conducted by trained operators in accordance with the instructions by the manufacturers. And for best results, tests should be performed within the first 5 to 7 days following the onset of symptoms to avoid the higher risk of false negatives. And they do not recommend an RDT testing in settings or populations with low prevalence of disease. And this includes screening at point of entry, prior to travel or elective surgery, and in these settings where you're unable to confirm testing by NAT. Okay, so moving on to RDT use in Fiji. So recently the Ministry of Health released an advisory on the use of antigen rapid diagnostic kits in Fiji. And that advisory is available on the Ministry of Health and Medical Services website. I would go to it now, but I think I will, my screen sharing won't extend to that. But if you look on the Ministry of Health and Medical Services website and you click the tab that says COVID-19, there will be a section there that says antigen testing, and it will it has the statement by the Ministry of Health that was just released this week on antigen RDT testing. And I will go through the statement now, so you, but just for your reference, that statement is available on the website. So we recently started using WHO approved antigen RDTs in combination with RT-PCR testing to try and increase our testing capacity and improve test turnaround time in high prevalence areas. We do not recommend that antigen RDTs are used in areas of low prevalence of COVID-19. So for Fiji, we don't recommend using antigen RDTs in the Northern Division nor in the Eastern Division. The ministry, the RDTs that we use, and the only ones that we recommend and allow, that we are allowing into Fiji, are the ones that are on the WHO EUL, or ones that are on the Australian Therapeutic Goods Administration TGA list as well. So on the WHO EUL, there are about 3 kits from 2 manufacturers. And on the TGA, there are just over 20 tests. Okay, so in Fiji, where can RDT antigen kits be used? So in areas of Fiji where there's high prevalence, so when we have said that there is community transmission, so essentially that's all of Viti level. We do not recommend using it in other areas of Fiji. We also recommend using it in large work sites, healthcare settings, and highly populated communities alongside PCR testing. So what samples are collected? We recommend nasopharyngeal samples. However, if you're using the RDT to conduct regular screening of the same group of people, for example, healthcare workers, then it's acceptable to do a nasal swab, a nasal mid-turbinate swab. We don't allow RDTs that require saliva or any other samples currently. For the collection of samples, only trained healthcare workers should be collecting the samples as demonstrated by Shalini, and they should wear the appropriate PPE for the collection of the samples. Interpretation, again, so the point is that we require that antigen RDTs are used under the supervision of a registered medical doctor, and this doctor will be responsible for interpreting that test result according to ministry protocols and ensuring that the result is reported to the ministry and advising the patient according to those protocols. So in settings with high prevalence, a positive RDT result means the patient is considered positive for COVID-19. There is no need for any validation of that result. However, if someone is in a high prevalence setting and they test RDT negative and they have symptoms, that result must be validated with the RT-PCR, and that person must self-isolate and behave as if they have COVID-19 while they're awaiting that result. However, if you are doing the RDT testing in a low prevalence setting, any result must be validated with the PCR test. Okay, so how do you use the antigen RDT results? As I've talked about already, if you have symptoms, if the person has symptoms and returns a negative result, the person should self-isolate and wait for their PCR test result. The antigen RDT cannot be used to clear contacts of cases from having to undergo 14-day quarantine. If you're a primary contact of case, you still have to undergo that 14-day quarantine regardless of the antigen RDT result. And you cannot use an antigen RDT result to clear an individual to travel from a high prevalence area to a low prevalence area. So if someone is crossing the containment borders from Suva and going to Nandi, or Suva and going to the Northern Division, you cannot use an RDT for this purpose. And if you're using the RDT tool to screen asymptomatic people, example in the workplace, this must be done regularly. So that's every day or every second day. And noting that you have a higher risk of a false negative result in people who have no symptoms. Oops. I'm sorry, I think I seem to have misplaced one of my slides. Let me just, I wanted to end in a summary which shows you exactly the algorithms that we are using for screening for COVID-19 RDT testing. Okay. So this is the algorithm that's being used within the Ministry of Health. Can you see my screen, Dr. Alipate?
Yep, go ahead.
You can see the algorithm?
No.
No.
Okay, hold on. Can you see it now?
Roger.
Okay, good. Okay, so this is one of two algorithms that we have for using RDTs. This algorithm is for community-based sampling. So for people who are symptomatic and present to health facilities, or contacts of cases, symptomatic high-risk groups, or if you're doing a transfer or admission to hospital, including to the maternity unit. So first, if a person is symptomatic for less than or equal to 7 days, you collect a nasopharyngeal swab and you conduct the RDT. If the RDT is positive, then you treat that person as a positive case, you isolate and you inform the divisional response team. If that person is RDT negative, you re-swab using a new swab, a new nasopharyngeal swab in a universal transport medium, and you refer the sample for RT-PCR and you note the RDT results on the lab form. In the meantime, while they're waiting for the test result, the person should quarantine. And if they test positive, you manage them as a positive case. If they test negative and they're a contact of a case, they still need to complete their 14 days of quarantine. However, if someone is symptomatic more than 7 days, if they're asymptomatic or they're asymptomatic contact of a case, we recommend that you do not use an RDT, that you send a nasopharyngeal sample for RT-PCR or GeneXpert, and that person needs to quarantine while awaiting results. So this is a quick note here also that if a person, it's a reminder that if a person is symptomatic and RDT negative in a place with community transmission, then you must maintain a high index of suspicion and isolate that patient while you're confirming the result by RT-PCR. The second algorithm that I have is about screening. So this is different. So this is screening of high-risk groups, including healthcare workers. I hope you can still see my screen. Okay, you should see that now. So this is still the same one. Dr. Alipate, you can see my screen. It should say screening of high-risk groups.
Oh, this says COVID-19 antigen algorithm, community-based sampling.
Okay, hold on again. Okay, this one should say high-risk groups. Can you see it?
Yep, got it.
Screening of high-risk groups. Okay, so this is the algorithm for screening of high-risk groups, which includes healthcare workers, other frontline workers, dialysis unit patients. So it's assumed that people in this group will be tested using RDTs at regularly scheduled intervals, for example, daily or every 2 days. So for people in this group, it's acceptable to do a nasal swab because, of course, as I think a lot of us would have had a nasopharyngeal swab at least once, and it's not comfortable at all and not something you want to be doing every day. So a nasal swab is acceptable because we anticipate that if you're doing it every day or every second day, the sensitivity actually goes up and you'll be able to pick out a case faster. So of course you need to be using only the RDTs approved by the Ministry of Health and Medical Services. So people in this group that you're using as screening, if they're symptomatic, you collect a nasopharyngeal swab or a nasal swab and conduct the RDT. If they're RDT positive, you manage as a positive case as normal. If they're RDT negative, you re-swab and you do the RT-PCR, and they must isolate while they're waiting for the PCR result. If the person is asymptomatic, which happens a lot, particularly for healthcare workers, if you're doing regular screening, you collect the swab. If they're RDT negative, you manage them as negative. But I would also recommend that you do a weekly RT-PCR swab as a supplement to the RDT. If they're positive on that asymptomatic swab, again, you will manage them as a positive case. And again, the reminder, if they're symptomatic and RDT negative, you should treat them still as positive and isolate them until you get a negative PCR result. So I know that was quite a lot to take in all at once. I think the take-home message that I would have here definitely is, yes, antigen testing, antigen RDT is very useful, particularly for our frontline teams. When you have a patient in front of you and they're symptomatic and you're in an area with a high level of community transmission, because you will get a result within 30 minutes. And if you get a positive result, you're able to put them into the appropriate care pathway if they're someone who's at high risk of severe disease. However, they must be used with caution and understanding all of their limitations. And you must ensure that you're following all the protocols from the Ministry of Health and Medical Services, including the algorithms that I have just shown. The reporting is also very important, and in the advisory from the Ministry of Health, which I'm unable to pull up right now, it has a very clear reporting line for the results of COVID, of this RDT testing. So let me just, I'm just going to pull up the advisory so you can actually see that. Okay, can you see my screen?
Yep, set.
Okay, so this is the Ministry of Health's website. You'll see this tab up here. It's got COVID-19. You click on the tab and antigen testing, and you'll come to this screen. So it's got the advisory from the Ministry of Health, most of which I've already gone through. Reporting of results, all results, positive and negative results, should be reported to the ministry. And this is the email address for the RDT results. This is compulsory. As you all know, COVID-19 is a notifiable disease, and it's actually mandated by law that you are reporting according to the Ministry of Health's requirements. For organizations that are wanting to import antigen RDT kits into the country, the Fiji Medicinal Products Board has to be contacted for approval and to obtain an import permit. And this is the contact for the board. Thank you very much for listening. Thank you for bearing with me. And I thank also the Fiji CDC team for taking the time out to do that demonstration. Handing back to you, Dr. Alipatia. I'm open for any questions, of course.
Naka, thank you, colleagues. If you want to ask Dr. Alicia a question, please feel free to use the chat. If not, you can raise your hand and then we'll allow you to unmute yourselves and ask a question. So Dr. Alicia, we know that there's been quite a few RDTs that have come in. and some of them might not be the ones that are on the list. Is there some sort of penalty, or what's your advice to clinics that are using these RDTs that might not be on the recommended list?
Well, first of all, I would recommend that you do not use them. As I'd put in my presentation, the RDTs that we have approved for use have been evaluated by the World Health Organization or by the Australian TGA. And as you can see, even then, even the RDTs that we have approved, they have variable performance based on one thing, that is the prevalence, because a positive predictive value of a test is dependent upon the prevalence of the disease in a country as well. So even the ones that we have approved have limitations to them. And because there are thousands of RDT kits out there, you cannot, it's very difficult to just start using something. And unfortunately, a lot of the RDTs and the professionals that are using them, you're looking at the insert, the package insert of the kit, and you're seeing, okay, the sensitivity is 90-something%, the specificity is this, but that is the information that is provided by the manufacturer. This is not, those kits are not independently evaluated like the ones we have approved for import into Fiji. So please, don't use those kits if they're not on the list that Ministry of Health has issued. The danger of those kits as well, what we're really trying to avoid is people using them to clear themselves from what we have already advised from the Ministry of Health. So we've said, if you live in Suvarnasori and you develop symptoms of COVID-19, you should assume you have COVID-19, stay home and isolate for 14 days. If we have people going out and using RDTs, particularly the ones that we have not approved, and you're getting a negative result, it's very likely those people will just clear themselves and then they're out and about in the community. They're infecting more people, and most importantly, they're exposing and infecting people who are vulnerable to severe disease. So please, we're asking that you don't use those RDTs that are not on the list. And if you are using the RDTs that are on the list, be very aware of how they should be used. So if you have someone who's symptomatic and they test negative with these RDTs, please, that needs to be confirmed by PCR, or if you can't confirm by PCR, just treat that person as positive and ask them to self-isolate for 14 days or until their symptoms go away. Thank you.
Question here, what do you do with an invalid RDT? Do you do PCR or?
I think it would really depend on the circumstances. So if you're in a hospital setting and you really need that result, so I know the maternity units are using them. If you get an invalid RDT, I would definitely recommend that you send a sample for PCR in it. And all the major hospitals, the divisional hospitals have the gene expert machines. So I would recommend that you send that sample for PCR.
Thank you. And following on from that question is from a GP, how do you actually send a swab from a private clinic for RT-PCR to the Ministry of Health for patients who may be symptomatic that have a negative RDT?
Okay. So as you know, the testing policy, it depends where you are. So in Suvarnasori, we are not asking people who just have symptoms for COVID-19 to get tested. We're saying that if you fall into a high-risk group category, so if you're over the age of 50, if you have comorbidities or NCDs, then you should come in to get swabbed and tested. That may be by RDT, that may be by PCR. We do not encourage people to come in just to get tested for just for symptoms. So it depends. If that person is falling into that category, yes, you can send a sample to the Ministry of Health, to Fiji CDC for testing. You can send that sample to one of the, if you're in the Western Division, to the other labs that are in the Western Division, the Lotoko Hospital or the Nandi Hospital. But yes, it depends on where you are. If in the Western Division, if someone is symptomatic, It doesn't matter if they fall within those high-risk groups. We are still testing symptomatic people in the Western Division, but the policy is different within Suva-no-Sori.
Vinay, thank you. I think the question was related to how do you actually send it from a private lab to the CDC? Sorry, not from a private, say, GP practice to the CDC.
Oh, okay. You'll have to call up the CDC. The phone number is, I'll put it in the chat later. But you'd have to contact the CDC to first confirm that they're able to accept the sample, and because you'll also have to have the swabber. So we do have private facilities already sending us samples, but again, the person needs to be within that high-risk group if you're within Suva-no-Sori, if you're doing the sampling within Suva-no-Sori. So over the age of 50 have comorbidity, but please contact the CDC if you'd like to send a sample up.
A question coming in from a private GP again regarding individual sales of the RDTs to non-clinical people. So I think some pharmacies are selling it, and some patients are even requesting GPs to come home and perform the swab at home because they've already purchased the kits. Your advice on this?
Yeah, so the Ministry of Health is not encouraging that, and we will likely be taking action in the near future to try and stop that. The issue with that, of course, is, as I mentioned, we don't want people clearing themselves using any of these tests. If someone is symptomatic and they're testing negative and they're saying that, okay, I don't have COVID because of these RDTs, that's a problem for us. And it's very clear in our statement that the situations where RDTs should be used, and above all, they need to be used under the supervision of a registered medical doctor, because it will be the responsibility of that doctor to interpret the test and advise the patient about isolation and the result of the test. So we are not recommending that at all, and we will be taking action in the future to reduce the incidence of that.
So some other possibly practical applications, say for example a business that has lots of employees in a area of high prevalence, and they want to get a GP on board to be able to run the tests for their employers to clear them before coming back to work. Would that be something that is a possibility?
Yes, so that's covered a bit in our statement. So essentially, if that program of screening in a large organization, and a few organizations are already doing that, is to happen, it needs to be under the supervision of a registered medical doctor. So that doctor takes on the responsibility of reviewing all of these results, interpreting these results, and giving the appropriate advice. So you saw that the second algorithm I put up was a screening algorithm. So you can use that algorithm to test people in a large organization, but you must be doing the test regularly. So every day, every second day, to be able to be getting the best utilization out of that sample. Because as I mentioned, if you're testing asymptomatic people, the chance of a false negative is much higher, because that's just the nature of that test. So in the advisory, there's an email there for where the GPs or the lab can be sending the result. If you send an email to that email address, you'll also get the template for reporting results on that. But we would prefer, we've also asked that, as much as possible, we would want this RDT testing to happen within a lab setting. So ideally, if a private GP is wanting to order a test, you would send the test request to the lab, in maybe a private lab, and that whole interaction is within the lab setting and to the private GP, so that the testing is done under controlled conditions, and that, as Shalini has mentioned, you really do need to follow the instructions of the test that you're doing or else you actually increase your chance of inaccurate results. So yes, again, everything needs to be done under the supervision of a medical doctor, a registered medical doctor, and that doctor will be taking the responsibility of that testing and the interpretation of the testing and advising the patient according to Ministry of Health protocols.
Awesome, thank you, Vinay. And so is the Ministry of Health and Fiji CDC going to be running trainings for medical officers or health staff who are going to be using the tests?
So we'll be releasing our protocols. The issue is that, you know, for every single test, so there are 3 tests on the WHO list, which we've demonstrated, Shalini and the team have demonstrated how to use today. On the TGA list, there are over 20 testers. So those tests would be the way to use those tests is specific to those particular tests that are being used. So that really needs, that's why we're asking that labs, even private labs, are the ones that conduct that testing over anything else. If there's specific requests to do that testing within private organizations, please email the Ministry of Health, the Permanent Secretary, etc., so that we can ensure that you are following the proper protocols in doing that testing.
Thank you very much, Dr. Alicia and colleagues, Vinaka Wakaleu, for taking time out on a busy Friday evening. I would like to thank Dr. Alicia and the team at the Fiji CDC for the presentation today on the rapid diagnostic tests. It's still very new ground that we are breaking, and we would like to work very closely with the Ministry of Health to ensure that we have a standard of testing that we can all rely on. So thank you, colleagues. Thank you, Dr. Alicia and the Fiji CDC. Once again, everyone, have a good night. Have an awesome weekend. We'll be sending out the list of the next set of webinars soon, so stay tuned. Stay safe, stay COVID safe, and we'll see you again very, very soon. Vinaka.
Vinaka.